So welcome everybody. This is the Caregiver Education Program for ALS FTD, provided both by the ALS Association and the Hershey Medical Center, Department of Neurology. Our aim today is to have an interactive, relevant, hands-on. So we're going to begin our program with giving content and information, but we're going to put everybody to work learning how to problem solve your own individual situations and go through a process of sorting out hopefully some ways in which you can manage some problems you're being faced with. Caregiving can be a rewarding experience if you have the right tools and the right support. So our goal today is to try to give you some tools and the support and resources to be able to help manage what you're experiencing. Your honest feedback at the end of this session is essential. It has guided us every step of the way, and we have found the most important thing that we get from doing this is learning from you all what we then give to other caregivers, because your individual learnings and circumstances and what you tell us are really shape what we tell other caregivers. We're learning in this together. What we know from our families is that they want to talk to other family members who are facing the same kind of challenges. So that's why we asked you to place your name and contact information. If people are interested in sharing, we will release those names to each other. If not, we will delete them. So think about that at the end of the session. But we will not share any contact information unless you think that's something that you want to share in contact with each other. But our families tell us sometimes it's helpful. Weeks or months from now, be able to talk with someone else who's experienced those kinds of problems. So our agenda today are welcome and introductions. We asked you to complete 2 questionnaires. One was about your understanding about fronto-temporal dysfunction. The other one was about behaviors that you may be seeing in your own individual circumstances. And so those will help sort of focus us and guide us in giving you some feedback about how to move forward. We're going to talk about what is ALS or fronto-temporal dementia or dysfunction, how to manage difficult behaviors, and particularly how to approach problem-solving techniques for managing behaviors. We're going to talk about the questionnaires and then obviously fill out some evaluations. We have refreshments and socializing, meaning that, again, people find it's useful to talk to other people, not us, but talk to other people. You can get a hold of us all the time. It's important to talk to each other. So, again, the session outline is we're going to talk about the basics of dementia, managing behaviors, and Judy's going to do problem-solving techniques. So this is the basics. The most common cause of cognitive behavioral changes in ALS are fronto-temporal dementia. The challenge in ALS is that just as the other muscles change gradually over time, thinking, the muscles of thinking, the cognitive, the cortex may be affected and gradually change over time. So that you may see no changes, or you may see mild thinking changes or cognitive changes or behavioral changes. Or they may gradually increase to what is called in the medical language fronto-temporal dementia. So that it's helpful to understand that this is not a cut and dry situation, that it's a spectrum of dysfunction. Just like you see dysfunction and changes in the muscles of the body, there may be dysfunction and changes in the brain. So mild changes may progress to dementia or they may not. We really have to assess that change individually as where the person is at that time. The term FTD in this presentation will refer to cognitive behavioral changes in ALS. So those are patients who have a fairly significant presentation of symptoms and are further along the spectrum than what I've been able to identify as some mild changes that may occur within the disease. So exactly what is frontotemporal FTD? So as you see, this is the anatomy of the brain, and the frontal lobe, that's here, is an important part, and we're going to talk about what happens when changes occur in that area of the brain. We also talk about temporal lobe, that green area, and that is also particularly affected in ALS. And there are different changes that occur there that your loved one may be presenting with. So it's helpful to sort of understand where on the body the changes are occurring, because there are associated behaviors that occur for each of those areas. And those are the kinds of things that we can identify in the testing that we do. So the frontal lobes, those are responsible for the multitasker, the gentleman up on the right-hand side. They're responsible for higher order thinking. I don't know if multitasking is higher order thinking or not. However, it is how we manage it, and it occurs executively. Imagine that as a CEO of a company does. There's planning, they organize, they integrate information from many different parts of the organization, just like the frontal lobe integrates information from your arms and your legs and all of the body. It's integrated in the frontal cortex. It is the place in our brain that initiates or starts a task or a project. And it also tells us how to follow social rules. Social intelligence is embedded in the frontal part of the brain, and it's a high level integration and functioning. So that tells us how to be socially acceptable. And it adjusts our behavior according to a situation. So that if I burst in here and everybody was attentive and listening and quiet, and I was loud and disruptive, that frontal part of my brain helps me to readjust to a social situation. The temporal lobe, that green area on the side of our brain, is responsible for languaging. It helps us produce language either by speaking or writing, and it helps us understand words as they're spoken. It helps us put words together in a meaningful way, and it guides our spelling and writing. And it helps us also interpret the tone of other people, so that helps us understand socially what people are saying. It gives us that social consciousness. So what does dementia mean? Dementia is a loss of brain function that occurs with certain diseases. It can affect memory, thinking, language, judgment, and behavior. The actual changes of the brain are the things that are causing this dementia, so that the changes produced by the disease itself, the ALS, cause changes. And just like ALS is a progressive disease, this dementia we have found is also progressive, meaning that we anticipate that it will continue to change and get worse. Mm-hmm. It's interesting, this morning when I got my emails and I looked at, I get articles that come over from the neurology, and what was a new article that was identified today is that they've done imaging in ALS patients, and that the cortex is thinned in the disease just like the other muscles of the body. And that the amount of thinning of the cortex in the brain is actually associated to the degree of dysfunction and the progression of the disease itself. So what we've been seeing and what you've been experiencing as family members is actually now being able to be documented in the research. So there's lots of jargon that we had to wade through, because we are not neuropsychologists, but we had to wade through what this was being called. And the reason that there's confusion in what is often called subtypes is because there are different areas of the brain being affected. So what it looks like for us as people experiencing this in our patients and family members depends on which areas in the brain are being affected. The reason we want to give you this is because this is the kinds of things that you're going to see, you may see. So that they call this behavioral variant of FTD. Means that you can have changes in behavior or personality where a person may be inappropriate or rude or childlike. So the changes of the brain can actually manifest as behavioral changes. There is a term that's given to the changes that affect language, and that's progressive non-fluent aphasia, which I can never remember unless I'm reading it from a slide. What that means is that the person can understand what someone says, but they can't put their own thoughts into words or actually write it. And they have difficulty word finding, so that when you try to speak with a person, they know what they want to say, but they can't find a word to express it adequately. The next subcategory is called semantic dementia, and that is where a person is still able to speak, but the content that they speak doesn't have very much meaning. So they have the language, but the familiar words, they don't have, they may string words together, but they don't really have a significant meaning, or the meaning isn't conveying what they're trying to tell us. But you can see that there are different ways in which the cognitive changes prevent, dependent upon the areas of the brain that are affected. So does everyone with FTD have the same symptoms? No. Someone with FTD can present with a number of different ways, whichever brain regions are affected. There are 3 primary subtypes, and as the disease gets worse, the symptoms progress. So what does this mean? Cognitive, behavioral, and language changes occur. What are the cognitive symptoms? These are the kinds of things that we see. They may have difficulty understanding complex ideas. They may have difficulty reasoning and making decisions. So what we generally experience is that it makes sense to us. It would make sense to somebody else. But for them, it just doesn't seem to make sense. For an example, if you're falling down and you find that if you use a walker, you don't fall down, one would think that A plus B equals C. But for people who lose their ability to reason and make these connections, people say, well, I know, they don't say, they just walk without their walker. Because their mind doesn't have the capacity to make associations and reason in the way that they did before. People are shaking their heads and saying, oh. They have difficulty organizing their thoughts and activities because organization is an executive frontal piece of the brain. They have difficulty organizing their thoughts. They may have scattered thoughts. They may have difficulty recognizing that there's something wrong. They lack insight, so that they have difficulty understanding that you as a caregiver can't be there 24 hours a day, sitting next to them. They just have an inability to see into is probably a good way to describe. They're seeing into a situation or making sense of it. They have difficulty ignoring distractions. So something may call their attention away, and they don't have the ability to refocus. And they have difficulty with empathy or understanding your point of view. We, as a way to help others understand our point, try to tell them again. And that's not effective. Trying to repeat our position, repeat information, and thinking that if we tell the person often enough or loud enough, as we increasingly become frustrated, that they'll understand that. We frequently will identify a person that's having a problem when we've told them recommendations 2 and 3 times on a clinic visit, and the behavior hasn't changed, their response is the same. And that's because these areas, their ability to take that, organize it, and integrate it into change or behaviors has been lost. If there's a problem in language, there's a breakdown in communication. So there's difficulty processing. Common words don't seem to make sense anymore. They make errors in speech, and sometimes these are very subtle but increase over time. An example is they may change words that they were able to say before, or they may pause and have difficulty finding a word. They can't think of the right word for an object. And their speech becomes slower and slower. And it's not totally dependent on their capacity for muscle articulation and movement. It's that their thought process has slowed. And so that you may, if you think back 6 months or a year ago, the cadence and speed at which they were speaking to you may be very, very different. And it's actually slower because they're having difficulty processing. They lose the ability to spell and use basic grammar. And you might see that when people start to write and you read their writing, so that you can see that they're missing words, their spelling is different, there's many, many errors in grammar. And it's like words start falling off the page when they write because they're losing that capacity. And lastly, there's maybe a change in behavior. There are changes in interactions with people. They vary. A person can be inappropriate with a loss of awareness of social rules. They may have angry outbursts or become unpredictable. Sometimes they become very aggressive. And sometimes they have unsafe behaviors. Frequently they have unsafe behaviors because if they have a behavioral manifestation of the disease, there's the behavioral component, but also as their physical aspects decline, they don't have the ability to match what's happening with their body to keeping themselves safe. They can't put those two together. They also may have a loss of emotional connection to other people, and that is that they may have decreased empathy and also social apathy. Some people become hyperactive and become aggressive, where others become very, very flat. And family members will say, well, I can't just get them to do anything anymore. And it's because they've lost interest or the ability to engage with others socially. There may be an increase in undesired behaviors or more acting out. So that if you can imagine, as a child increases their ability and matures and their brain focuses and develops, they understand social cues and they gradually increase internal control of their behavior. As the brain decreases in its function, they revert or lose the capacity to manage themselves socially and behaviorally. So their behavior sometimes will resemble childlike behavior or teenage behavior, or sometimes toddler behavior, in that they don't have the capacity to manage their emotions and their behavior. Or again, they may have a decrease in activity, withdrawing from interests in loved ones, and really need to be prompted because they can't initiate themselves or plan forward and say, okay, tomorrow I'm going to go do this, because they lack that planning capacity. These are the kinds of things that then we see happening. There may be excessiveness, excessive spending, opening new accounts, giving money away, or a fixation on money. And this is one of the symptoms that we've seen particularly in family members, and it's something that we want to talk about because it's really an important aspect for you to understand as trying to understand how to manage and support someone. We find people describing that they become stuck on ideas or actions. They become fixated. So that if this is what they're going to do, it has to be this way and only this way. Only this way. So you just feel like you can't move them off of whatever it is today. And if you work through that, something else sticks them. So they get stuck someplace else. So you feel like, oh, I've gotten them there, but something else fixates them tomorrow. And it's like their brain has lost the flexibility. Just like their muscles have lost flexibility, their thinking has lost flexibility. Change in eating behaviors. This obsessiveness, this stuckness may be around food, so that they may eat sweets and all they want to do is eat chocolate. Or they may recognize, even though they can't swallow anymore, they're going to drink. No matter what, they're going to drink. And they may eat and gain weight. We have a number of people who gain excessive weight because they've lost the internal control to manage their appetite. Also, neglecting personal hygiene. They've lost social cues that it's appropriate for them to take a bath every day or every week, to get dressed, to do things that were normally socially within the things that they saw as useful and normal. So how does FTD compare to Alzheimer's disease? They're both cognitive changes. Most common dementia, fronto-temporal dementia, is most common in middle-aged adults, and it often begins before age 65. Memory so this is fronto-temporal dementia. Memory is usually not affected in FTD, but in Alzheimer's, that's a primary symptom. So that in Alzheimer's, there's the concern of family members, they're going to forget who I am, they're not going to know their family, they're going to forget events. That doesn't happen. It's gone. People will lose the ability to communicate, they will lose the ability to think, to manage their own affairs, but when they come to clinic, they always remember us. So that connection, that is very different between an Alzheimer's and a frontotemporal dementia. So how do we diagnose it? Judy talked about this earlier, but it requires information from a variety of sources because of the different parts of the brain that may be affected. So that's why we always do a caregiver interview, people who are with the person who can tell us about changes in behavior. We do a cognitive or a neuropsychological testing, and then there are also sometimes imaging which can be able to identify the physical changes. There's no quick or easy test available to diagnose frontotemporal dementia, and that's probably familiar to you because there's no quick and easy test to diagnose ALS. How common is this? The research has documented that 50% of patients with ALS present as cognitively normal. 40% present as having mild cognitive behavioral changes. And 10% of the patients present with a full spectrum of the disease. So that you can see that at least 50% of the population is affected and at different degrees. When ALS and frontotemporal disease occur together, something happens. And one is that the disease progression is usually faster, the survival is shorter, and their safety risk is higher. So that families tell us that those pieces of information are helpful in helping them understand what's happening. The disease progresses quicker when we see both of these together. The life expectancy is shorter, and as you know, the falls and every different complications are higher because of the person's own innate capacity to understand how to manage themselves and the more rapid nature of the disease. So what does this mean? People with ALS and FTD are less likely to follow their treatments. Caregivers should assume that medication management. You can't assume that the person has the capacity to sort out their medications. You need to find creative approaches to implementing changes in care. When changes happen, you have to start thinking differently about that, and we're going to spend time with how to do that. Begin implementing changes before they are absolutely necessary, because change goes slowly. So you have to be thinking because the other person isn't. You need to be thinking ahead more so that you can accommodate, knowing that it's going to take some more planning and creativity to get the person either safe or using or doing the things that will help them. People with ALS and FTD have symptoms that will continue to change over time. So you need to consider a combination of medication and behavioral management problems. It's not only one thing, and as things change, you may need to reassess and and alter the approach. Seek outside sources of support and information, and we're going to give you some places for that. And learn how to care for yourself, because just as this disease is more demanding on the patient, the demand on the caregiver is extreme. They have done studies in caregiving and ALS, and the subgroup of caregivers who you are identified as those people who are caring for people with cognitive changes and ALS are the most highly stressed and the most highly impacted. People with ALS and FTD may lose reasoning and decision making. So you need to constantly assess a person's capacity to drive. Really recognize that things like power tools that they might have been using 6 months ago might not be safe because they can't understand how to manage those. Using different equipment. Really looking at how to manage the person's financial accounts and how to put safeguards in place because they lose the capacity to manage that themselves. Addressing legal issues earlier in the disease, because fronto-temporal dementia will eventually interfere with one's ability to participate in treatment planning. So having discussions about how they would feel about decisions about interventions such as feeding tubes and ventilators and other medical treatments. It's important to recognize that a POA, both for healthcare and decision making, is essential, and for that to be done early in the disease because we know that the disease will progress and their thinking capacity will change. The bottom line is that the caregiver should develop an understanding of the patient's goals so that if they're not able to verbalize them, that you understand what they were hoping for themselves. So, the take-home points are that there are actual brain changes as the cause of the cognitive behavioral symptoms. Dementia symptoms will continue to worsen over time, and the caregiver will play an important role in shared decision-making with the patient.